Good morning. Today will be our last lecture in the entire course. And just to remind you that this lecture is included in the midterm, the written midterm that you're having today. Probably some of you have started it, like you have started, let's say, the lab part of it. So the written part is also included. This lecture is included in the written part. Okay. And also I received some questions about the lab. This time you have, I think, 5 videos for the virtual lab. So it's all these videos are included, and for that reason, the lab part in midterm 3 will constitute 10% of your mark, not 5% like you used to have in midterm 1 and midterm 2. Okay, so it will be 10% of your mark because there are 5 videos there. Okay, yeah.
Same amount of questions though, or will there be more questions?
Same number of questions. Yeah, but the amount is more. Yeah. And again, I would like to remind you that there is no virtual lab or no lab questions in the final exam. The final exam will be 2 hours, 90 questions, MCQ questions, and will include the entire material from the beginning until the end. Okay? So wish you all the best. Sorry?
That's all day at home all day? Yes.
Yes. Sorry.
The final exam.
The final exam will be on the 13th.
All day?
Yeah.
All day, yeah. Both exams, the midterm and the final will be all day exam. All day exam. Yeah.
There'll be no lab.
I think if you go back to Brightspace, you check that. We have already updated it. Yeah. Okay. So today we are going to go. Actually, we are going to go back to the cellular levels again. But in this time we're going to deal with gametes, not with somatic cells. When we started the term, we started with somatic cells, but now we're going to go with gametes, the male and female gametes, the secondary oocyte of the female and the sperm of the male. They're going to join together, and this is by the process of fertilization. After fertilization, then these 2 cells, after forming one zygote is going to multiply and will form mulberry mass, which is going to be implanted in the uterus. The uterus at that time will be prepared for that implantation, and then the embryo will start developing. The first 8 weeks after fertilization, it's called the embryonic development, and then after that it will be the fetal development. The whole process from fertilization until labor, it is 38 weeks. So today we're going to cover this period. So the gestation period, which is the time span from fertilization to birth, it is 38 weeks, and it starts from the day of fertilization. Usually it is counted as 40 weeks from the day of the last menstrual period. So because you are not sure about the time of fertilization, so you ask the patient or you ask the pregnant woman about her last menstrual period. That will be the day when bleeding started, and this day is about 2 weeks earlier than the day of ovulation. Fertilization cannot take place until ovulation takes place, so the entire period is considered as 40 weeks minus 2 weeks between menstruation and ovulation, so the actual period is 38 weeks. And when you want to count the expected day of delivery, therefore you will ask about the last menstrual period, which is the day of first bleeding, add 9 months to it, and then add 1 week, and you will come up with the expected day of delivery. Add 9 months, add 1 week, and this will come up as 40 weeks, but actually it is 38 weeks from the day of conception, from the day of fertilization, because there are 2 weeks earlier which should be subtracted. Now, the whole period is before birth is called the prenatal period, and after birth it's the postnatal period. And the prenatal period is therefore in 2 stages. Is the embryological development, which is in the first 8 weeks after fertilization, and then it's called the fetal development. So during the first 8 weeks it's called the embryo, and after that it's called the fetus. Okay. Usually obstetricians use trimesters. So there's the first trimester, second trimester, and third trimester. Each one is 3 months. The most critical one is the first trimester of pregnancy, which more or less it coincides with the embryological development, because at that time the woman should be very careful, because the tissues are forming, the organs are forming at that time. So they are more prone to the effects of radiation, more prone to the effects of drugs, infections. The first trimester is very, very critical period, which is, as I said, it coincides with the embryological development. After that, from 8 weeks onwards, it will be, from 9 weeks onwards, it will be the development of systems. And in the third trimester, actually, it's just a mere growth. It's not actual development. So the 2 gametes, as we mentioned that before, they contain the haploid number of chromosomes, the sperm and the secondary oocyte, and when they meet, they will join together and form the diploid number of chromosomes in the zygote. Fertilization, as we mentioned, takes place in the uterine tube, and to be specific, it occurs in the ampullary portion of the uterine tube, and this means that the ovum, after it's being ovulated, by the way, the ovum here, just keep in mind that the word ovum is a little bit different from the oocyte. The oocyte is one cell here. The biggest cell is the secondary oocyte. But what is ovulated is not only the oocyte, but it is surrounded by the zona pellucida, which is the homogeneous layer of glycoprotein material, and surrounded by granulosa cells, which form the corona radiata. So the corona radiata, the zona pellucida, and the secondary oocyte together are referred to as the ovum, and this is the part that is ovulated from the follicle, which is the Graafian follicle or the tertiary follicle. And this ovum is going to be attracted by the fimbria, as we mentioned that before, and then peristalsis in the wall and the cilia, which are going to beat in the lining epithelium, and then it is going to meet the sperm from the vagina. This ovum can be viable up to 24 hours. Sperms can be viable up to 48 hours. So there are like 3 days between intercourse and fertilization that can take place, because the sperm can be viable for 48 hours. The ovum is less likely to be viable. It's might be viable only for 12, but maximum for 24 hours, and it will die. Now what happens is that the sperm is going to penetrate. See, this is the ovum. There's a secondary oocyte. This secondary oocyte is in the second meiotic division, and is surrounded by the zona pellucida, which is the homogeneous layer here, acellular. And these are the cells of the corona radiata. The sperms are going to penetrate. They are going to pass in between the cells of the corona radiata. Of course, the flagellum plays an important role here, especially when the sperm goes into the uterus. It will, some of the sperm will undergo what we call capacitation. So they will become, their flagellum will beat very hard, and so they will become fast, and at the same time they can penetrate, they can pass between these two cells, between these multiple cells, until they reach the zona pellucida, where the acrosome, which is the lysosome present at the tip, will digest and touch the mucous, touch the cell membrane of the secondary oocyte. At that time, there will be a reaction by the oocyte. The oocyte will produce substances that will make the zona pellucida hard, and so that no other sperm can penetrate. So it's only one sperm. Once it penetrates, touches the cell membrane, then there will be a reaction that prevents other sperms from penetrating, because the substances that are produced from the cytoplasm of the secondary oocyte are going to harden the zona pellucida. Okay? So the zona pellucida becomes impermeable to other sperms. Now, what happens later on is that when the sperm enters, as I said, the secondary oocyte here is in the second meiotic division, and the oocyte will complete its meiotic division here and result in the formation of two cells which are unequal in size. One of them is the ovum, and the other one is, we call it the polar body. This is just a nucleus surrounded by a very small amount of cytoplasm, and it's going to be absorbed and removed. And it's only the ovum that is going to unite with the nucleus of the sperm and form the zygote. So the genetic material are coming from both N, coming from the paternal side, and another N coming from the maternal side. Yet, there is more genetic material coming from the maternal side. You know why? The maternal side contributes more genetic material to us than the paternal. Why? Because? Yes. Because there is mitochondrial DNA, and the mitochondria are present in the cytoplasm, and the cytoplasm belongs to the oocyte. Okay? So the mitochondrial DNA is always maternal. Now, this is how twins are formed. Either we have dizygotic or monozygotic twins. In the dizygotic twins, there is the release of two oocytes, and they will be fertilized. As I mentioned earlier, before, that we said that it's only one of the Graafian follicles. Multiple follicles will start developing during each menstrual cycle. About 20%, 20 of them, they will develop, but only one of them will ovulate. But in some women, sometimes two of them will ovulate. So we have two ova, and these two ova have the possibility to be fertilized by two sperms, and this will result in dizygotic twins. So this is two oocytes fertilized by two separate sperms. Usually it's only one oocyte that is ovulated, but because there are multiple follicles developing, sometimes it's more than one ovum that is released. And so the dizygotic twins or fraternal twins are different as any other two siblings. But in case of the identical twins or the monozygotic twins, it's the fertilized ovum that's going to form two individuals. So the two individuals are exactly the same, exactly the same genetic material, and definitely they are the same sex. That is the monozygotic twins. If these two individuals will fail to separate from each other, and this results in the conjoined twins. So here, as I said, that there will be fertilization takes place in the ampulla of the uterine tube, and then after fertilization, cleavage or cell division will start. So the zygote will form two cells, the two cells will form four cells, and then the four cells will form 8 and then 16 cell stage. And we will have a mass of cells, which is called the moriola, moriola because it looks like a mulberry, and then the moriola will reach the uterus and will be implanted. That will be about 5 days after ovulation. If this process does not take place, if the fertilized ovum fails to reach the uterus for one reason or another, maybe infection, maybe narrowing of the tubes, then the zygote will grow within the uterine tube, and this is called ectopic pregnancy, a kind of ectopic pregnancy which is called the tubal pregnancy. By the way, is not all the ectopic pregnancies are tubal pregnancies, because there are other kinds of ectopic pregnancy. Like an example here, like if the ovum is released from the ovary and fail to reach the uterine tube, there's still a possibility that the sperm will reach the ovum outside the uterine tube, fertilize the ovum, and the ovum will grow in the peritoneal cavity. This is another type of ectopic pregnancy. So ectopic pregnancy is not always tubal, but most of the time it's tubal pregnancy, and because the tube is narrow, it cannot distend. So usually after 8 weeks, this will result in very severe pain and rupture of the tube and result in very severe bleeding. It's a life-threatening situation. It's more common in smokers because nicotine paralyzes the cilia. Remember the role of cilia in moving the ovum or the fertilized ovum toward the uterus. If there are no cilia, then this movement will be reduced. So after cleavage, we will have the moriola, which is multiple cells here. Look here that these groups of cells which were derived from the fertilized ovum, they are still, till now, they are covered by the zona pellucida. Until this stage, they are covered by the zona pellucida. So actually they are not increasing in size. They are still encapsulated with that covering, but the resultant cells from the cell division are smaller and smaller in size, and it will result in the formation, as I said, of the moriola, which moriola means mulberry because the whole mass looks like a mulberry. It's a solid ball. What happens later on is that fluid will start to appear within the cell mass. Fluid appears, zona pellucida is removed, and fluid appears and then will form a cyst. And the cells now are called blastomeres, and the cyst is called the blastocyst. Okay, so the blastocyst or the blastocyst cavity. Again, you can see that there is polarization of cells. So some of the cells here are called the inner cell mass, and the other cells which are surrounding are called the outer cell mass. So the inner cell mass is usually at one pole of this ball, and this is called the embryoblast. The embryoblast is the actual cells that are going to form later on. They will form the embryo, while the outer cell mass is called the trophoblast, and the trophoblast is going to contribute to the formation of the placenta. So now it's the blastocyst that's going to implant itself, and this occurs about 6 or 7 days after fertilization, because it takes about 5 days from fertilization until the blastocyst reaches the uterus, and then it implants into the uterus. It implants into the uterus in such a way that the embryoblast will be closely related to the endometrium. Remember here that the endometrium, this is the stratum functionalis. It is in its secretory phase. It is highly vascular. There's a lot of secretions that will provide nourishment for the implanted blastocyst. And the embryoblast will be on the side of the endometrium. And then, as you can see here, that the embryoblast the cells will differentiate into a hypoblast and an epiblast, and this will later on form the endoderm and ectoderm. Remember the germ cell layers. The outer cell mass, as I said, will form the cytotrophoblast, and these cells are going to produce enzymes which digest the endometrium, make a space for the implantation. But at the same time, and this is very important, this cytotrophoblast will produce a hormone. And this hormone is called the human chorionic gonadotropin. This hormone maintains the mucosa of the uterus. Remember that what maintains the mucosa of the uterus after ovulation, we mentioned that last time, that the remaining part of the follicle, of the Graafian follicle, will form the corpus luteum. And this is going to produce progesterone and estrogen to maintain the secretory phase of the endometrium. Now, this role the corpus luteum itself, if no fertilization takes place, it will form the corpus albicans. But if fertilization takes place, then the trophoblast will produce the whole human chorionic gonadotropin, and this will maintain the corpus luteum to maintain the uterus, to maintain the lining of the uterus. And this role will be later on taken by the placenta, which means here that this hormone, human chorionic gonadotropin, if it is secreted, then definitely pregnancy is taking place. So this is the human chorionic gonadotropin is the hormone that forms the basis of pregnancy test. And so the pregnancy test would be like after 1 week of missing the cycle, which means that 3 weeks after fertilization, it will be positive in the urine of the pregnant woman. Because the human chorionic gonadotropin is produced by the cytotrophoblast. The cytotrophoblast is only formed after fertilization. So we said that the embryoblast here will form the hypoblast and the epiblast, and these will form the ectoderm and the endoderm, and then another layer will appear and in between them, and this is called the mesoderm, and these are the three embryonic layers. We mentioned about these layers. We mentioned about them in the I think the second lecture or third lecture probably, when we were dealing with the tissues, and we said that these tissues have their origins from the embryonic layers. So for the endoderm, for example, produces the epithelial lining of the GI and respiratory passages. The mesoderm is the layer that produces the connective tissue, whether muscle or bone or other connective tissue, and the ectoderm is for the skin and the nervous tissue. Yes?
So HCG is secreted when you are pregnant. So
Yeah.
how do you end up with a false positive on a pregnancy test?
How you end up?
Because if that's what a pregnancy test measures, right, is the HCG?
Yes.
So if you're not pregnant, then you shouldn't be secreting it.
Yes.
So how do you end up with a false positive?
What's the false positive
It's when
pregnancy test?
It's like
Like
when
it's
you,
you're pregnant, but you're not actually.
yeah, that happens like 1% of the time maybe.
That's like a hormone imbalance, if anything. Usually you get a false
It's
negative.
maybe something false in the kid, probably. I have no idea about the false
So
positive
some
pregnancy
people
test.
have the hormone diseases where they do like, it says positive, but they go to the doctor and it's negative.
But usually, as far as I know, is that the pregnancy test, if it is negative in the first time, it might become positive later on, because it's 100% positive after 2 weeks. After 1 week, it's not 100%, but there is possibility. I mean, after 1 week of missing the menstrual cycle, If it is negative, this does not exclude pregnancy, because there is still possibility after 2 weeks it will become positive. That's what I mean. Okay? Yeah. So again, negative pregnancy test does not exclude pregnancy. Okay? Now, returning back to the 3 germ layers, ectoderm, mesoderm, and endoderm, and these are the derivatives. We have studied that before. And then you can see here that the ectoderm, the cells of the ectoderm will multiply and will form a cavity here, which is called the amniotic cavity. This cavity is actually going to grow and surround the whole embryo later on. This is at its beginning, but later on it will surround the entire embryo, and it will provide like a cushion for shock absorption. It will prevent adhesion, and will also regulate the body temperature of the fetus. So it's very important, this fluid there. And this fluid, part of it is coming from the mother. It's a transudate from the blood. And the other part is actually because the embryo, as it grows, it's going to drink that fluid, and then it's going to be excreted in the urine. So partly it is in the urine of the embryo, and partly it is contributed to the mother. But there are a lot of embryonic cells present in that fluid. That's why tapping of this fluid is important, especially to detect some abnormalities in the embryo. And this is what we call amniocentesis. Another sac will be formed, but this sac is formed temporarily, and this is called the yolk sac. And then it's going to regress. As the embryo grows, the yolk sac is going to regress. But this sac actually is very important, because this is where the blood cells primarily develop. Yes?
Is the amniotic fluid what comes out of the embryo?
Exactly, yes. Yeah, so it will remain, and it will be the water that comes out at the beginning of labor. That's the amniotic fluid. So the yolk sac is going to regress later on, but part of it goes into the placenta, forming a finger-like projection here called the allantois. But all these are going to regress later on, and the amniotic cavity is going to dominate. The chorion, this is the chorion is derived from the cytotrophoblast. Remember here, the outer cell mass here, the cytotrophoblast, will form the chorion. And you can see here that the chorion has villi, multiple villi, which are called chorionic villi. This is the embryonic part of the placenta. The remaining part of the placenta is provided by, or the maternal part of the placenta is provided by the endometrium. And here at this location, between these chorionic villi and the sinusoids of blood that are present in the mother, exchange will take place. In other words, here in the placenta, it is not the continuation. The blood vessels that are present in the umbilical cord are not the continuation of the mother's blood vessels, because there is an exchange here. There is a barrier at the placenta between the chorionic villi of the fetus, which are going to form the umbilical vessels, and between the endometrium of the mother, where the sinusoids of blood are located. So the endometrium here can be described in 3 parts. We call it decidua basalis. Decidua basalis is actually the maternal contribution to the placenta. And these are the chorionic villi, the embryonic contribution of the placenta. The other part of the endometrium is called the decidua capsularis, and this is going to be very thin and then will disappear, because the embryo will later on occupy the entire uterine cavity. And as you can see here, the space, the entire space will be the amnion. Look at the yolk sac now becoming rudimentary, very small. This is the yolk sac. and the remaining part of the endometrium, which is not involved in the placenta, is called the decidua parietalis. This is what I mentioned about the placenta. It has two parts. It has the embryonic part, which are the chorionic villi, and the maternal part, which are the sinusoids of blood, and exchange is taking place here through membranes. And diffusion of oxygen, nutrients, wastes take place. The placenta also stores some nutrients, produces hormones. Actually, the placenta will maintain the cells of the placenta. They will produce hormones that will maintain the endometrium, because the corpus luteum will only be able to maintain the endometrium after pregnancy, after about 3 months after pregnancy. After that, it will not be able to maintain it, so it will be maintained by hormones that are produced by the placenta. So diffusion takes place through the placenta. Hormones are produced. It acts as a barrier to microorganisms. Not all microorganisms. Some of the microorganisms might pass through the placenta. It acts as a barrier to some drugs, but some of the drugs can also pass through the placenta. That's why drugs are not recommended to be given to pregnant women, especially, as I mentioned, in the first trimester of pregnancy. This is the placenta. The placenta will be released after birth. That will be called the third stage of labor, the placental stage. And you can see here that the placenta is connected to the embryo or to the fetus at that time, by the umbilical cord. This umbilical cord, in fact, contains connective tissue, embryonic connective tissue, and 3 vessels, 2 arteries and 1 vein. So 2 umbilical arteries and 1 umbilical vein. The umbilical arteries, they carry the blood to the placenta, and the umbilical vein carries oxygenated blood to the fetus. Okay? So the umbilical arteries, therefore, in this case, the umbilical arteries, they carry deoxygenated blood and return it to the mother, while the umbilical vein is carrying oxygenated blood from the mother to the embryo. So it's something like the pulmonary arteries and pulmonary veins. Here, the vein carries oxygenated blood and the arteries carry deoxygenated blood. And they are embedded in connective tissue. This is a primitive or embryonic connective tissue called mesenchyme. We mentioned about that previously when we dealt with the connective tissue. The stub of the umbilical cord will fall about 2 weeks after delivery, and the remaining part is called the umbilicus, as you know. This is the amniocentesis, usually done under ultrasound guidance. See here, and needle pass through the abdominal wall and the uterus to take the amniotic sample of amniotic fluid to examine for genetic defects, because there are a lot of cells in the amniotic fluid here. Now, what happens to the mother during pregnancy is that, as you can see here, that the uterus almost occupies the entire abdominal cavity. This is probably 36 weeks. It's full-term infant, so you can see that it almost fills the entire abdominal cavity. It will compress on abdominal viscera, mainly gastrointestinal tract. So the pregnant mother might suffer from heartburn because of reflux of the stomach contents into the esophagus. Remember, we mentioned about the gastroesophageal junction. We said that there is no anatomical sphincter there. It's a physiological sphincter. So that's why it can be easily overcome by pressure from below, and will result in gastric contents going up into the esophagus. The esophagus is not designed, let's say, to withstand the gastric juice, because it's a stratified squamous epithelium, while the mucosa of the stomach has a lot of mucus, and this mucus protects it from digestion. So that's why this results in heartburn when the contents of the stomach go to the incorrect place, and that is into the esophagus. Also, pressure on the large intestine will result in constipation, especially at the later stages of pregnancy. Pressure on the urinary bladder here will not provide enough space for the urinary bladder to distend. So that's why the woman will have frequency of micturition, because the bladder cannot distend a lot and contain a large amount of urine, and there will be urgency of micturition as well. Compression on the veins, because the veins are easily compressed, easier than the arteries. The arteries, remember, they have muscular walls, thick muscular walls, so they are not as easily compressed as the veins. So the veins will be compressed. So compression of the inferior vena cava here will result in reduction of and the return of blood to the heart, and will increase the venous blood in the lower part of the body, resulting in dilated veins. So they will have, for example, they will have varicose veins. Remember, the superficial veins can be easily seen, or they might have edema because of the interstitial fluid cannot return easily into the veins because of high pressure in the veins. Compression of renal vessels can result in renal hypertension. Remember, when we dealt with the urinary system, we mentioned that there is something called renin-angiotensin mechanism. When the blood pressure reduces, then renin will be produced by the kidney, and this will result in release of angiotensin, and this will result in the release of aldosterone, increasing the blood pressure, increasing the blood volume. That's what happens when the blood pressure reduces or the volume of the blood reduces. But here, it's not the blood pressure is going down, it's not the volume of blood that is reducing. What happens is that the renal arteries are compressed, so the kidney will think as if there is reduced blood pressure and try to compensate for that. That's why hypertension will be common in pregnant women because of that. So there are a lot of, let's say, pressure symptoms. Most of these are pressure symptoms. Now, what happens during delivery is not clearly understood until now how, which triggers exactly, what triggers delivery. That's why you can see here it's a cycle. We don't know where is the beginning, where is the end. So it's uterine contractions will force the fetus. You know, the wall of the fundus and the body of the uterus, they have muscle fibers in them, but the cervix, as I mentioned earlier, is only connective tissue. It's not muscle fibers. So it will, the presenting part of the fetus, which is usually the head, not necessarily the head, but usually the head, the presenting part, will press on the cervix will dilate, and this will release nerve impulses, or result in nerve impulses that will result in the release of oxytocin. Oxytocin that is released from the posterior pituitary will cause more contraction of the muscles of the uterus. Oxytocin, remember that not only acts here, but it also acts on the mammary gland and cause the ejection of milk. So oxytocin will cause more contractions, producing more stretch of the cervix. And that's why during delivery, when they examine a woman during labor, usually they report that she is now like one finger dilated, two fingers dilated, and so on. This reflects the size of the cervix, the dilation of the cervix, measurement of the dilation of the cervix, and the measurement of the progress of delivery. So true labor begins when contractions occur at regular intervals, and there is dilation of the cervix with discharge of blood-containing mucus in the cervical canal. And then false labor might produce pain, but the uterine contractions are irregular intervals, and when you examine the patient, you will find that the cervix is not dilated. Here, the cervix is dilated, and then this leads to what we call rupture of membranes. The membranes are the amniotic membrane, and it is the amniotic fluid that's going to pour out. So rupture of the amniotic sac and dilation of the cervix. This is the first stage of labor, and then the second stage is the expulsion because of the contraction of the muscles of the uterus. It depends. It might be very short, might take longer time. And then after the expulsion of the fetus, it takes about half an hour to expel the placenta, which is the third stage of labor. What happens after delivery in the newborn? There are a lot of changes taking place. I'm not going to go into details of these changes, but what happens is that the reduced carbon dioxide levels in the blood will cause the muscular contractions and the first breath of the newborn. And in case of the cardiovascular system, you can see here that we have, this is the umbilical cord. It has a vein. This is the umbilical vein, 2 arteries. The vein is in red because it contains oxygenated blood from the mother, and this oxygenated blood goes to the right atrium, and then from the right atrium it bypasses the right ventricle, goes directly to the left atrium through an opening which is called foramen ovale. So all of these are going to close after birth. This one, the umbilical vein, will become a cord of fibrous tissue, and then foramen ovale, which is present in the interatrial septum, closes. If it fails to close, then you have what we call interatrial septal defect. And also these umbilical arteries are going to be closed and become like fibrous cords, and they are still present in our body. When you dissect a person, you will find all these remnants are there, and they are like radiating from the side of the umbilicus, but on the inside of the anterior abdominal wall. Any questions? Okay, thank you very much, and best wishes.
Thank you. Thank you.
Can you imagine?
Wait, no one else is watching.